Hello, everybody. My name is Benjamin Day,
And I am Jillian Mason.
and this is Medicare for All, the podcast for everybody who needs health care. Now, for today's episode, we obviously spent a lot of time griping about the power of corporate health insurance in our healthcare system on this podcast. But you would expect that taxpayer-funded public programs, especially for our most vulnerable friends and neighbors, would be free from that kind of profiteering, right? Sadly, no, unfortunately not. Medicaid, the public program that serves the lowest income Americans, plus some people with disabilities, and a lot of the country's long-term care, has been extensively privatized in most states. Hoping to trim budgets, most usually, all these states have sort of outsourced Medicaid recipients to what are called Medicaid Managed Care Organizations, which are actually just private health insurance companies. And with private insurance comes the barriers to care that we all know, unfortunately, a little too well. Prior authorizations, denial of claims, narrow networks, the whole gamut. And this is kind of part of the business model for publicly funded, privately run insurance plans, which is the more care that these insurance companies can avoid paying for, the more money they get to keep from these capitated payments. So
that sounds great for them.
Yes, but don't get too depressed because we have a ray of sunshine today. We're going to be talking about a state that's showing us a different way of providing care. In 2012, Connecticut kicked the private insurance-run Medicaid managed care organizations out of their Medicaid program. They essentially deprivatized. It's funny, we barely even have a word for like publicizing, making public. It's like they deprivatized their Medicaid program. So they took on big insurance and they won, which doesn't happen that often, unfortunately. So our guest today is really going to walk us through how all of that went down and what the outcomes have been.
Oh, fantastic. Yes, so not all heroes wear capes, and evidence thereof is Sheldon Taubman, who is a litigation attorney for Disability Rights Connecticut. Sheldon has been at Disability Rights Connecticut, which is the protection and advocacy system for people with disabilities in Connecticut, since 2021. Before that, he was a staff attorney with the New Haven Legal Assistance Association, where he spent 30 years representing and working on behalf of Medicaid enrollees. He engages in a variety of strategies on behalf of people with disabilities, from litigation to legislative advocacy and public education through the media and webinars and other means. Sheldon sits on several subcommittees under Connecticut's Medicaid Advisory Committee, as well as the committee itself. And he is super awesome, and we're so excited to have you here. Welcome, Sheldon.
Thank you. I've never been referred to as super awesome, so that's
it's not too late.
We really like unlikely heroes on this show, and I mean, you're unlikely only in the fact that you are not wearing a cape. So, Sheldon, you have basically spent your entire career, really advocating for healthcare and advocating for and with people who with disabilities. And so we wanted to know exactly what motivated you to do that, what created that kind of passion for healthcare and advocacy.
Well, I would say that I was, when I went to law school, I had the passion for, helping low-income folks, working on issues that affect low-income folks. I guess that was always an interest of mine. And I first started in legal services in Philadelphia, where I was at community legal services, and one of the areas was health law, and I did Medicaid work, and then for a couple of years, and I moved up to Connecticut and continued to do that kind of work, and it just becomes, you become engrossed in it, and you also develop expertise, whether you want to or not, and then once you have that expertise, you realize you can help people, right? So
right.
It made sense to develop more and see where I could impact change and specifically where I could help more than one person. right?
Oh, that's really, that must be a real thing, right? Being a lawyer, like you're going in every time, it's one case, one person, right? So you're not getting a chance to really get a bite into that, like systemic reform. So,
Well, or another way to put it is it's very frustrating because you help one person, but for example, if you're dealing with issues involving delays in a government bureaucracy, if you help one person, that's really great. But actually, in the end, you've accomplished nothing. The reason is that somebody else paid for that because I
right.
got involved and I made noise. I'm the lawyer, blah, blah, blah. I got the person to the front of the line and somebody else got delayed. So I didn't really fix anything. I didn't,
Yep.
and net effect, even the person in front of me feels better and I feel good about it. I didn't accomplish anything. So that's where, in cases where we have been involved in that issue of delays, where we brought, class action lawsuits to challenge the delays overall so that we don't steal from Peter to pay Paul, whatever. Yeah. But basically, the answer to your question is the need is great and I could help, but see that need. And I developed some tools which were useful for it. And along the way, besides wanting to have affect systemic change, you help more than one person. I also realized that, well, a lot of this is policy. That is to say, it's law to some degree, and maybe lawsuits, maybe class action lawsuits, but it's also policy and persuading policymakers, legislators, the governor, whatever, that this is just a bad idea. It may be a bad idea for everybody except, for example, for-profit insurance companies' bottom lines, which is sort of what we're talking about today, which was that this model, which everybody bought into, had no close. It didn't accomplish any of the things that we were told it would accomplish. And instead, it sucked dollars out of the system.
So maybe I can ask you some more details about that. 2012, this was before the Affordable Care Act. Or before most of I think the expansion happened in 2014, maybe, the Medicaid expansion. But what did Connecticut's Medicaid program look like back then before you guys won this sort of monumental reform? Right. You were just starting to allude to the problems with the system there.
Right. So to be clear, it was bifurcated. So basically, the family and child populations, back then called Husky, were in this capitated for-profit model. The folks who were eligible for Medicaid because they were elderly or disabled were not. They were in a fee-for-service system. And this
Can you, I'm so sorry to make you back up, but just like explain it to me like I'm a small child. I know a lot about decapitation, but I know very little about capitation. What exactly, how would you define capitation? Okay. What does it mean for people like me who have the insurance brain of a small child?
So let's just back up the clock a little bit. It's in 1995 in Connecticut, and it's around that in a lot of states. So before that, roughly, states provide their Medicaid program, run their Medicaid program directly. They have a state governmental agency that does it. And they pay providers, all kinds, from hospitals and doctors and pharmacies. They pay them for the service, whatever the service is. It's an office visit, it's an operation. They pay them directly. And it's an indemnity kind of program where the provider does the thing and then gets indemnified for what they did. The state makes all the decisions. It decides how much it's going to pay, what the provider rates are, right? Who the providers are, if there's prior authorization, whatever. The state is in control of all of that. Around the mid-90s, states started, including Connecticut, started saying, well, maybe we'll contract with insurance companies and they will take it over. Now, the key is that in the former model, the financial risk is on the state. That is to say, if there's somebody needs a heart transplant, very expensive, the state pays for that, right? They're on the hook for that. Under a capitated model, capitated means per person, right? A capitated payment system.
Per person, that's so much easier. Okay, go on.
Per person, yeah, capitation means per person, usually per person per month, PM. We're going to pay this private insurance company X dollars. It's negotiated or it's presented in RFP, but some dollars per member per month, and it's on you. The financial risk is on you. And if it's more expensive, then we pay you. Sorry. And if you deny a lot of claims, so you don't pay, there's not so much healthcare you pay out the door, you get to keep it, right? So that's what the basic difference is with a capitated model. That's what we did with our child and family population, whereas elderly disabled folks were in a different program and were not subject to the state, was still taking on the risk and still setting all the rules and all that. This is before, as you said, this is before the ACA's Medicaid expansions went into effect in the states where it went into effect, which is not all, but most. And
hello from Texas.
right. And then there's a third population, which is miscellaneous adults, miscellaneous low-income adults. But before that, those were our two big populations. And again, only the kids, families, and pregnant people, those groups, were in this capitated model.
All right. I often feel like a miscellaneous adult. So I mean, the period you're talking about, this is really just the frenzy of managed care, right? That kind of swept the nation, both in the private sector and in the
managed care
sector.
madness.
Exactly. Which this was, the new promise for cost control is going to be managing how people access their healthcare and sort of letting insurance companies interfere with the decision making of doctors and their patients. So yeah, that's helpful, and it's interesting because even today, a lot of people blame fee-for-service for everything that's wrong with the healthcare system, and there's a big push now for capitation. Was it just the capitation you think that was the problem? That obviously creates all these incentives for insurance companies to like game the system, or do you think there was and I actually don't know, were the insurers in Connecticut then for profit, or were they not for profit, or did you feel like there's a profit motive operating as well on top of all that?
Let me answer it by telling you, fast forward to what happened in 2012, because to answer your question, I mean, it's a very long, convoluted history we don't have time for. But at the end, there were 3 capitated insurers contracting in our Medicaid program, 2 of which were very large, publicly traded for-profit companies you've all heard of, called United Healthcare and Aetna, now owned by CVS. And then the third was a homegrown nonprofit managed care organization, Connecticut only, but in fact, technically nonprofit. Those were the 3 entities we had. So your question is, well, what is the problem? Is the problem capitation? I think the answer to that is yes. And let me support that answer by telling you what happened. So it was a very, very long campaign that was like, 12 years long, that I basically co-led with Ellen Andrews with the Connecticut Health Policy Project and many others, with a pretty broad coalition. But when our new governor came in the beginning of 2011, he had heard enough. He had heard enough that this was a failure. It was not working. It was not doing what we were promised. It was very expensive. And a lot of the dollars, taxpayer dollars, were not going to healthcare. So he announced this. This is February of 2011. It was his first major policy announcement after taking office, like 3 weeks later. He said that by January coming up, which is at that point 11 months away, we're going to take the risk back, right? To use your term, deprivatize. So we're going to take the risk back here in Connecticut. And instead, we're going to do 2 things. It's going to be fee-for-service, but we're going to manage things. So we're going to contract with administrative service organizations on a non-risk basis, ASOs. And they will take on certain roles that the insurance companies used to do. We're going to contract with them, do an RFP, and we're going to do that actually in 4 areas. One is, most of it is medical, one is dental, one is behavioral health, and the last one is medical transportation. So we're going to do RFPs, and we're going to, on a non-risk basis, contract with these entities. And one of the things they're going to do is reviews. They're going to do medical necessity reviews in certain areas where we decide we should do prior authorization, but we are going to pay the bill. So this entity doesn't have a financial stake in denying the claims, and they can't make a whole bunch of money on top of everything by doing that, right? They get paid the same amount, one way or the other. And the second thing they said, the governor's people said, we're going to use patient-centered medical homes, which was something we really were pushing as the alternative to actually do what the MCOs claimed they did and never did, which is coordinating care. Right. So we had a small before the big change, we pushed very hard for a model, which some legislative leaders supported, a model of something called primary care case management, where primary care providers, besides office visits, also have a bigger role in coordinating care and are paid for doing that extremely important role. So that was the announcement in February 2011. And then we did that. And we then did the RFPs and we got contractors.
RFP is a request for proposals. So
Correct.
when you have state money, you have to request that people put in proposals.
Put it for bid,
yeah,
right.
for a bid.
So a fair process and make sure it's open to everybody and all that, and you lay out what's going to be expected of you if you contract. So that was done successfully to be effective for January of 2012. Now, the main ASO was the one that was an MCO, the nonprofit. The nonprofit MCO became the ASO on a non-risk basis for most for most medical. But some of them were for-profit. So, for example, behavioral health was contracted to a for-profit company. And by the way, that company had a terrible record when they were a subcapitated entity. New term, subcapitated. So the MCO typically then and around the country still will take a part of your body or a part of the bodies of all people. I'm going to take your head. I'm going to take your teeth. I'm going to subcapitate. So I'm going to pay them. I get my $300, $400 a month, whatever. I'm going to take a little bit of it and I'm going to pay this behavioral health company for the head, and you do the head. Okay. That company in turn has a financial incentive to not provide care. One of those companies, which was a subcontractor for at least one of the MCOs, it may have been two, I can't remember, was terrible. They routinely denied services. They were one of the we brought a lawsuit about this, and like they were in there because they were so terrible.
How did that translate to some of the experiences of your clients?
Can I answer that question by finishing this?
Sure. Yeah. Keep talking.
That company got the ASO contract under the managed, what we call managed fee for service system. And guess what? Completely shockingly, I'm not saying that facetiously, they were doing a good job. So to me,
that was a twist.
The point of the story is the difference is not really for-profit versus nonprofit. It's the incentive system. Both the for-profit and nonprofit administrative service organizations had no dog in the fight for their own bottom line based upon whether they approved or did not approve. So we have four different ASOs, some for profit, some not for profit. That didn't seem to make a difference. What mattered is they were paid on a non-risk basis. This is a long-winded way of answering your question. About what was it capitation or was it for profit? I'm not sure for profit is so problematic as long as they are paid in this way. And I would point out there's other models a lot of people don't know about. Traditional Medicare, for example, contracts with insurance companies on a non-risk basis to run certain parts, and it's sometimes regional, certain parts of the Medicare program, usually behind the scenes. That's okay. They're for profit. But it's not the system where they make money by denying claims and having small provider networks. To answer your question, were there problems with access to behavioral health under the Medicaid Managed Care system? I mean, I've ever heard the joke, is the Pope Catholic? It was horrendous. So basically, in 1999, when I started looking at this issue, 98 maybe, 99 started looking at this issue. So they had been around the MCOs for a few years. That was like the primary area where we were hearing the stories. So we did like meetings, lots of meetings with what's known as child guidance centers that serve the behavioral health needs of kids. And we'd have roundtables. We talked with all the providers, and it was just shocking. It was shocking the routine nature of what they were put through in order to wear them down. There was no question. It was meant to wear them down. So they'd ask for a few sessions, and they'd have to ask again, and then they'd get tired of it, and they'd say, "Okay, I'll move on to something else." Sometimes the MCOs would, or their subcapitated entity would allow a few visits without prior auth, but then the hammer comes down hard. So we heard all these stories. It was shocking. And so when we brought our first lawsuit in 1999, I think, that was like a big focus. We sued one particular MCO and the state, but the focus was largely about the behavioral health, not exclusively. It was also about due process, but it was the behavioral health aspect of it. And so that we fought that really hard. It was a disaster. And I guess at this point, it's really not that many years after that lawsuit was brought and ended in 2000. I think it was 2005, like 5 years later. The commissioner of the Department of Social Services at the time issued a memo saying to legislators, saying everything that we had been saying and been ridiculed for saying for years. This system is a failure. This system cannot be reformed. This system does not deliver and harms children. That in the memo. That's exactly that. That the kids are falling through the cracks. They're ending in the criminal justice system. They're ending up in the child welfare system simply because they could not timely get access to services. And that's because of capitation and then subcapitation. So it really was the sort of the focus initially of the problems with access created by the capitated managed care system.
Wow. Yeah, and sadly, the system you're describing there is what still a lot of us kind of have in our states today, not in Connecticut. I mean, some of the excesses of managed care may have been reined in a little bit over the decades, but I remember very recently, I live in Massachusetts, and the denial rates for these MCOs were like over 30% for one year. I mean, it was higher denial rates than you'd see in the private sector from private insurers who don't rely on government contractor taxpayer funded dollars. So just really kind of shocking stuff, and you can see all the incentives you were just talking about there.
Can I just ask a question? So today, of course, we know Connecticut as a state that is bought and paid for by insurance companies, right? Was this the case when you were starting out back in 1999? Yeah, I mean, tell me a little bit about what that dynamic was like politically, given just the tremendous power that insurance companies hold in Connecticut.
Yes, let me say that then and now, of course, people always puff up their own locale, but Hartford, Connecticut is often considered the insurance capital of the country. And it was true in 1995 when we went down this road, and it was true throughout the 10, 12-year campaign to get rid of them. United Healthcare, which is, of course, the largest insurance company in the world, I understand, has this tall building with United Healthcare right there, staring at the Capitol, or looking down on the Capitol. So we were fighting very powerful interests. It was difficult. There was definitely many legislators who, did not want to upset the big players there, and they also argued, and it ran ads about how they employ people. It's job, right?
Sure.
The last refuge of the scoundrel, it's about jobs. And so they would use that if you put us out of business, look what you lose, right? It's terrible. So it was a huge part of it. The lobbyists were constantly, giving misinformation to legislators and selling their wares. And, we are just nonprofits trying to counter it. And we did not have a lot of data. We didn't talk about accountability and about lack of data, but one of the, on top of all the problems with access, mostly due to prior authorization and limited provider networks, it was that you couldn't get information, right? So you couldn't, like you said, that 30% figure, it's like you couldn't get the data. So all we had until maybe the Secret Shopper survey, which I'm happy to talk about, was anecdotes of horrendous access. And we tell these stories. Whereas at the Medicaid Council back then, it was called the Medicaid Managed Care Council, the MCOs would take turns presenting wonderful glossy PowerPoints about how great they're doing, and they'd have some story of some poor person who they helped out and did wonderful things for her. It's like, oh, okay, that's
One
not
person, like you said,
sound
we
nice.
help one person.
No,
and
it was very hard for us to combat that. So with
Mhm.
they did have many lobbyists, and they were always up at the Capitol trying to persuade them. So it was a very, very tough fight at every step of the way. The litigation, the public hearings, every.
Yeah, when you first described the switch in Connecticut, you said all the evidence was there that the system was broken, that it was really harming people, and that the governor decided to prioritize changing it. And the only surprising part about that story is the governor decided to prioritize changing it, which in a lot of our states doesn't happen, even though the evidence is quite overwhelming that this type of a model doesn't work. So what was kind of the tipping point for what do you feel like was the tipping point for your campaign where you were actually able to reach, a gubernatorial candidate? Like
yeah,
that?
you mentioned that secret shopper survey too.
Yeah,
That sounds.
Yeah. Let's talk about the secret shopper survey, and then we'll get into the governor's decision. So one of the things that was always anecdotally complained about was the lack of access to providers. That you just can't get into it. I have my Medicaid card, but I can't actually see a specialist, particularly specialists.
The ghost networks, they call them now.
Yes,
right?
exactly. And by the way, online they had current lists. They just weren't accurate.
Right.
So a group, there was a lot of different things happening at the same time, but a community group, a bunch of activists and providers, I was actually not a part of it, decided that they wanted to, they theorized that the reason that the network was so small was that the providers were paid too little. So they asked the state to please produce data on how much what are their provider rates, and they gave them codes. These are people, including medical people, who knew what they were talking about. They said, give us your payment rates for these specialists, for these codes, these kinds of office visits, etc. We'd like to see what they are. And they sent that message to the state, and the state said, oh, we're really sorry, we don't have that information with the MCOs. We can't get that. And this sort of was the start of another round of litigation, which was under the Freedom of Information Act, which was ultimately successful. But where basically our Freedom of Information Commission and then a Superior Court affirmed the concept that we had laid out, which is that although they're not state entities, they're not state agencies, which is normally where FOIA applies, this is a situation where our statute is special, and it said that even state contractors, if they're performing the role of the governmental function, they could be subject to that responsibility. And so, that was litigated, but that was sort of what was going on, was trying to get the provider rates. But at the same time, other people were raising concerns about the limited networks. And so a group of providers, I think it was pediatricians, persuaded our state agency that they should check these lists. And the only way you can really validly check lists is to create, and it should be well designed, a secret shopper survey where you call it secret shopper because you're a shopper, I'm a Medicaid enrollee and I'm trying to buy healthcare, or I'm trying to get it, right? And so it's done in secret in that, and this is the design of the system. And the state of Connecticut, to their credit, did contract with a reputable auditing entity that they also contracted with on some other things. It was Mercer, and to do an analysis where they paid people to make calls to providers' offices listed as, currently enrolled in the particular MCO's plan. And it was I believe it was 5 categories of providers. And they would call, and to make it real, they had dummy numbers. So they would say, I'd like to make an appointment. And the person on the other line at the doctor's office would say, okay, what's your number? Because they check on the computer to see that you're really enrolled. So they would put the dummy number in that was pre-programmed to say, yes, they're enrolled. So that it was very, very kosher looking that this person really was on Medicaid and really wants an appointment. And then they record what happened. And across the board, with the various kinds of specialists, and then the pediatricians and the dentists, it was always the same. Only about 25% of the time could they get an appointment.
Right.
And the reasons ranged from, I kid you not, they're dead, the doctor. They don't have an office anymore to
because of their death.
That would be a potential reason. We don't participate in that plan. We participate in Medicaid, but not that plan. Or possibly we participate in that plan, but only for existing patients. We're not taking any new patients under that plan. So there were a whole host of reasons and excuses. I mean, even in a normal situation with normal insurance, there was a few times when you can't make the appointment for some reason, but this was overwhelming across the MCOs. And across, and by the way, at that point it was a different set of MCOs, just to be clear, because there's a long convoluted history in Connecticut. But at that time, the 4 MCOs were surveyed, including the 1 nonprofit and 3 for-profits. And it was about the same for all different kinds of specialists and providers in each plan. It was about 25%, 22% varied some, but it was really, really shocking. So that report came out around the time, it was kind of fortuitous timing, came out around the time that the result came through from all that litigation of the Freedom of Information Act. Not just, there were 2 steps of litigation, not just that you are subject to the FOIA, but also your excuse that, well, okay, we're subject to FOIA, but that particular information is proprietary and it's trade secrets. We can't produce it. And in the state law, we don't have to. And our attorney general weighed in on that. Now Senator Blumenthal was attorney general at the time, weighed in saying, nah, that's not a thing where you can make the state withhold it. It's an option. State doesn't have to withhold it. So the information finally came out, and lo and behold, the representation that the industry had been making for years and years and years is that we're better, we're superior. Because one of the things that's what's superior about us, we pay more than the Medicaid rates. Remember, on the elderly disabled side, the state paid directly setting the rates. We pay more than that. That's why we're so great. Turns out, wasn't true. A couple of little exceptions, but basically it wasn't true. And instead they paid crappy, about the same. And not only that, but for providers, it's not just, with managed care, capitated managed care, it's not just how much you get paid, it's also the grief. How much grief is there? And one of the things that really was wonderful when we got rid of them is providers, even those who didn't get pay raises, some did, the primary care providers did because of the ACA requirements coming in, but some of them did not get pay raises, but they signed up, even though they had in the past, at the same rates. Wow. Because the grief was taken away. And the 2 levels of grief, there's the prior authorization aspects, beating your head against the wall, spending hours fighting with a bunch of people who don't know medicine at all, just whose job it is to say no. And it's very time consuming and demoralizing if you're a provider trying to serve your patients, right? And then the second thing is getting paid, literally getting paid after the thing has gone through all the prior authorizations. It's got the rubber stamp saying approved and it's all good and everything.
They delay payments.
The provider submits the bill. Oh, they haven't gotten paid. And this kind of grief is such that providers just didn't want to participate. So all this came out at the same time that the providers were actually being ripped off and they weren't being paid adequately. And there's all this grief. And the networks are a lie. So we really publicized all of that. In addition to anecdotal stories about, individual people who can't get whatever services. And we put all that information, obviously the media was used extensively throughout the 12-year period. But in addition, we, made sure legislators knew about it. When there was a gubernatorial race, we as 501c3s, it's totally appropriate to, as long as you do it in an even-handed way, provide information to all candidates for a given office, which we did. To all governors, including gubernatorial candidates, including the really minor parties and all. We gave them everything, the same information, saying this is not working. This is really not working. And I think we were lucky that Daniel Malloy, who's the one who ran the election, did not have any background allegiance. He was a mayor of Stamford, not Hartford. Did not have any allegiance to the insurance industry. And instead, he looked at the hard facts of the access issues, how much it's costing, the increases they're demanding each year. And of course, we didn't talk about medical loss ratios, about the low medical loss ratios, particularly in the for-profit MCOs, meaning a large portion of the taxpayers' hard-earned dollars are not going to healthcare at all. Right?
Right.
Yeah.
Going to for profits.
Profits and administration. Yeah.
So we presented all that to
Mhm.
the candidates, and then once the governor won, and then there's that interim period where sometimes a new executive will create committees to like weigh in on certain issues, give me information. So I'm going to be leading the state or this country, and I need some briefing on various issues that I should consider. And so we approached those committees with our information, and they put out reports, and a couple of them, did recommend it's time to move on. So I think it was not that hard to lift, notwithstanding the politics of the insurance industry's power in Connecticut. It was possible for the governor's people to look at it in a hard-nosed way and say, this is just not working. And there's also the beginnings. Remember, I told you how bad it was for behavioral health. In 2005, 2006, we carved behavioral health out of it. It was not working. It was a failure. So we took that back and created ASOs once again to run things. And we did that early. And so we had done that. We had done a later carve out of dental and pharmacy. So we're over time, different RFPs are going out for another set of ASOs, but we're sort of cutting back. So by the time the new governor came in, there was also that.
I
This
see.
is like a trend we're just going to end.
Great. Yeah. And it's such a familiar experience to some people, especially in the sort of the exchanges, the state exchanges these days, which the extreme limited networks you're describing, which sometimes is called, rationing by inconvenience. It's like, it's so hard to get the care that you technically are entitled to that you just don't, you kind of forego needed care. And that has become really common. These super limited networks have become really common in the exchanges, but clearly pioneered by many of the Medicaid Managed Care organizations. What did you? I don't know. Do you have tips for other states who might be interested in moving in the same direction, or do you think this was just really unique to circumstances in Connecticut?
I don't think it was unique to Connecticut at all.
Yeah.
I think it's basically the same everywhere. And the overall recommendation is try to hold them accountable. So although in most states they don't, the vast majority of states do not have a law like ours that applied outside FOIA that applied outside of state agencies to the state private contractors. Most states don't have that, but you can still ask for it. You can say to the state, look, you're the big guy. You're paying them hundreds of millions of dollars a year, maybe billions. And like, for our money, we'd like a little bit of accountability. We'd like this data.
That's just good business.
Know your prior authorization rates for this and your prior authorization rates for that. And and how much you're paying. We need to know how much you're paying. Now that's a big fight because they're going to say it's proprietary, but we need this data. And you can do secret shopper surveys. And in fact, there's new rules coming out from the federal Medicaid agency that are designed to make that more robust. You can do secret shopper surveys to get data on, are those lists real or not? So basically, start now is my recommendation to advocates and providers in the other states. Start asking now of your state agency to get the data. Now, if you have problems with that, which of course we did, and most people will, the next step is, okay, so you publicize the fact that this big state agency that takes all of our taxpayer dollars does not want to hold contractors accountable for how the taxpayers' money is being spent. And I can tell you that at the end of our long, convoluted battle, our governor previous, our Republican governor, who was basically in lockstep with the MCOs and defending them, publicly broke with them saying, you don't want to be held accountable. We're not going to stand for that. Because of the publicity around that point. No politician wants to be on the side of saying we should not hold state contractors accountable for how the taxpayers' money is being spent. And that's the way you will get that data. Or either one or the other. Either you get the data, we sort of did both, or the industry will look really, really bad for being unwilling to provide it, such that in our state we had, editorials by the main newspaper saying these companies don't want to be accountable with our money. And if they won't be accountable, they should be kicked out. We don't need contractors who won't tell us how they're spending our money.
Yeah. Oh, that's great. So you made the argument on a kind of transparency basis, which is
Exactly
kind of bipartisan issue. That's terrific. Yeah.
Exactly.
And you put together a pretty large grassroots coalition. Ben and I are, of course, organizers, and so we love to hear about the organizing piece. So you put together a grassroots coalition that really, kind of helped to move this forward. Do you want to talk a little bit about that coalition and whether those folks are still around doing things right now?
To answer the last part of that, it's like, people move on, there's whole different groups and there's new nonprofits. And so, I work with different people on various issues. And you alluded, I think, Ben, at the beginning, and I'll say that it's a hot issue today, which is, I think it's a euphemism, value-based payment.
Yeah.
Fee for service is a bad thing, is the talking point. And the answer is value-based payment. So there's a whole nother coalition now that's pushing back on this value-based payment, which really means just putting financial risk on providers. So they have an incentive to deny care instead of an insurance company. That's really what it is.
Yeah.
But anyway, that's a different group. Now, it's been many years since we had the coalition, but the answer to your question, the first part of the question is, well, we had to work at it. We had to reach. I told you we met with all the child guidance centers and got providers, working with us and sharing stories with us. When we brought a lawsuit, they gave the named plaintiffs to us, pseudonyms and all. But we really had to develop that. And then, but when people came to us with stories, we would ask, hey, do you want to be part of this coalition?
Right.
And that way we could, when we had hearings, if we did sign-on letters, if we were, talking to the media and they need somebody to talk to who's been harmed by this, they have somebody, all those things were essential to the coalition.
So tell us, I guess this is the last question I have is, what happened after the reform? What were the outcomes like? What was the impact on patient access to care? Did a lot of the horror stories you're just describing to us clear up or get better, or are there still really significant challenges? I imagine there's still some significant challenges in any Medicaid program that have nothing to do with the payment model, but.
Correct. Our program is not perfect.
Yeah.
Our program has
there's a shocker.
significant problems in it. I would say the biggest problem is still in certain areas, not primary care, is specialists provider rates and behavioral health provider rates. But the good news is we know what those rates are exactly. And we not me, but the legislators, working with providers, working with advocates, we can move the ball forward, and we've started to move the ball forward through a full analysis of the various provider rates. So we can take action directly, not indirectly through this vague thing of throwing more money at the MCOs and hope they're going to raise the rates, but you'll never really know because the trade secret, all that. But the answer to your question is it was a huge improvement in access. That the I told you already that we a lot of providers signed up without getting more money. Being done with the MCOs was a real relief to them, and being able to actually they're still prior auth. There was still going to be prior auth, but it's not by people whose job it is. We're told by their boss, you have to deny so many claims. Right. And maybe you get a bonus. You get a bonus, by the way, for denying claims, because that's what the bosses want, because that's how we make our profit, right? So that was gone. And also, once the service was provided, whether it required prior auth or not, they got paid. So we really got more providers involved, but the prior authorization process, besides being more rational, was not nearly as burdensome. So people could gain access to services much more freely, or not freely, but appropriately. So that's sort of the access side of it. On the money side, according to the state, we've saved hundreds of, really at this point, billions of dollars. Wow. Because of all, and the Department of Social Services, the Medicaid, has put out many reports over the years explaining, all the money saved, what the trend was nationally at the time we did the diversions. So you really see it overall in the dollars out the door, but in addition on medical loss ratio. So our department's medical loss ratio, it varies a little bit, but it's basically about 97%.
Wow, that's like Medicare. Pretty.
Yeah, Medicare is
Yeah.
about the same. Traditional Medicare, not Medicare Advantage.
Yeah.
Real Medicare.
Real Medicare. So basically, almost all the taxpayers' dollars are actually going to healthcare when it's sent into the Medicaid program, versus what it was like then. And you know that the ACA has requirements of 85 or 80% medical loss ratios, which are terrible. And then, of course, there's gaming on that. Well, when we had the MCOs, they were worse than that. Some of them, not the nonprofit, but some of the others were just terrible. So basically, we had a higher percent, apart from the total dollars actually being less, a vastly higher percentage of those dollars were then going to healthcare. And lastly is the accountability piece. The ASOs only do basically what they're told to do. The data is held fully by DSS, and we can get that data, and DSS shares the data, and you don't have competing MCOs, hiding the data, doing the data in different ways. And by the way, spending money, taxpayer money, on advertising because they're competing with each other. This is a waste of money. So we basically got rid of all of that. And I think that our program has done very well, including through use much more of patient-centered medical homes, which I alluded to actually coordinate care, something that the industry always said they did. I mean, they said three things. We do it better, we do it cheaper, and we coordinate care in a way that's not possible without us. None of which is true. And when we got rid of them, we kind of proved that correct. And we also did develop a broad use. It's admittedly not as high a percentage of the population as we'd like. It's only about 50%. So that's a problem. But it does help a lot. And I will say beyond that, the ASOs, particularly the medical one and the behavioral health one, are also paid to do intensive case management. So people who are frequent flyers in the ER and other situations that are unmanaged, that's why it's called managed fee for service. We do actually manage the care in a fee for service payment environment.
Yeah. It's just a wild, it's just a wild story. It's amazing how this would be a radical solution to the problem. You're we found out that this wasn't working, and so we gathered evidence, and then we decided to stop the program, and people have done better. That shouldn't be such a fairy tale in our American society.
No, yeah, I mean, you didn't ask, I should say one other thing. You didn't ask, why do people, politicians, decision makers want to keep on a system that doesn't work, that's more expensive, that's inefficient, that provides poor care. And the reasons are not that complicated. One of the reasons is it's easier if you're a government agency to just write checks, right?
Yeah, sure.
And it's kind of predictable, how much it's going to be. And I will say that when we got rid of the MCOs, and at the press conference where this was announced, the reporter said, yeah, but what about the risks of the state? You're taking on the risk. And the answer by the budget director was, really? It's a huge group. So if you average out the transplants, it's very predictable. So it's not even true, but at least it sounds better, and it's certainly easier to just write a check than to actually run a program. So I think that's a bureaucratic reason for maintaining it, right? And then there's the lobbying. The industry spends a fortune of money to get and keep contracts with states.
Yeah.
They lobby the governors, they lobby everybody to try to convince them, that they can do this. And to the extent they can do it in some states, the campaign contributions obviously are a factor. And then lastly, in some places, I don't think it was a big deal in Connecticut, but certainly in some places, it's a very big deal, is ideology.
Right.
Yeah.
That privatized the reigning
Hello again from Texas.
Market-based, yes.
Privatized is better. It just because it is. It's the private sphere always does things better and more efficiently. Right? If you have that mindset, then that would apply to pretty much everything. the
Yeah.
motor vehicle department,
Yeah.
insurance under Medicaid.
Yeah.
So it makes sense that people who have that ideology would tend to see that. The problem is that sometimes they're resistant even to the facts. So when you show them the facts, geez, look at these medical loss ratios. Like, 25% of the taxpayers' dollars are not even going to healthcare. It's being wasted on marketing and salaries and profits. That's not really a good thing. They say, oh yeah, but overall it's more efficient anyway. And but
Wow. It's a lot of lost money.
Costing more money. No, actually, no, it's not.
I mean, when I think about Connecticut, I think about two things. One is health insurance, and then the other one is WWE, or professional wrestling. And it seems like a lot of the politics around this nationally work a lot like the WWE. The arguments are scripted in advance, and mostly, people win by hitting each other over the head with a chair, right? Not having substantive arguments. And so I just I'm fascinated by this example of people having a substantive political argument and arriving at a different solution. And it's sad that that is the case. But like I said, the rest of our country is the WWE in terms of our political way of doing things.
But the other analogy is to the Medicare Advantage versus real Medicare, traditional Medicare.
Absolutely.
It's basically the same thing, and the companies are often the same. Literally, it's the same business model.
Yeah. United and Humana and all the
take
same
the money,
guys.
smaller network, lots of prior auth, and then you can make the difference. I think that a bit of a difference is that in the Medicare situation, there's a lot of gaming with the risk adjustments in terms of how much money they get from CMS. So they sort of make money in two ways. They're overpaid on the top, and then they game the risk adjustment, so they get more, make people look sicker than they are, so they get paid more. For them, the cap rates go higher, and then on the other end, they deny services, and they get to make money in both ways. Not so much the first thing in Medicaid, but other than that, the Medicaid and Medicare models involving privatization are very similar here. And as you pointed out, Ben, Medicare, traditional Medicare, it's 97% is about the medical loss ratio in traditional Medicare, which is very, very good and very efficient. And that's with using insurance companies for some limited things on a non-risk basis. And Connecticut, gosh, 97% running the Medicaid program, maintaining risk, contracting with non-risk ASOs to run certain limited things, namely insurance companies contracted. Some of them are for profit to do these specific things. Two different places, government, somewhat different populations, two different levels of government. But isn't it interesting that they both end up about the same,
similar dynamics,
very small cost going to administration compared to healthcare? So maybe there's something to be said for that, and maybe somebody should look at why it is that we're doing so well with efficiency in both traditional Medicare and Connecticut's managed fee-for-service system, and we're not doing well in traditional, in Medicare Advantage or in the MCO land.
Yeah, and I think, well, we don't need to slip into the Medicare Advantage discussion. That could be a podcast, and I think has been several podcast episodes for us. But yeah, there are different dynamics just because Medicare Advantage plans can kind of offer lower premiums and things like that, which don't really apply in the Medicaid sphere. There's not quite the same pushback from some enrollees. But yeah, this is really inspiring. I mean, I think it's kind of it is just a metaphor for the whole healthcare system where, markets really don't work. They tend to drive up costs instead of driving down costs, which was the idea behind the market ideology. And when we look at countries that have Medicare for all systems, it's a lot like kind of what you described as the new Connecticut Medicaid model. Some countries like Germany, they do pay private insurers to administer some things, but they're not allowed to make money off of the system, or they don't have any incentive. They're not allowed to control who they enroll and who they don't enroll. They have to accept everyone. The rules are so constrained that they really have not much room to do damage, and definitely not room to drive up costs. So that's really interesting to me. And thank you so much for joining us.
Yeah,
it's really exciting. I know that I think for my information here is a little bit dated, but my understanding is that for a lot of the really big national insurance companies, they're making most of their money these days off of public programs like Medicaid and Medicare, and declining amount of profits are coming from the private sector, from employment-based. So this is, I think they consider it existential, but this is also a campaign that could be picked up by other states. I'm a little surprised that a bunch of other states didn't immediately follow suit after Connecticut especially proved that it works. But it's not too late, I don't think. So
let's get on it.
Some folks
That's
think
right.
about this in other states, and you'll hear from us if they do. So I want to just conclude by thanking the podcast team. Our podcast manager is Angelique Davis. Our show notes writer and the researcher who came up with this idea for this episode was Jerry Katz, and our audio editor was Craig Stanton. So, don't forget to like this episode, subscribe to the Medicare for All podcast on whatever platform you use. And this show is a project of the Healthcare Now Education Fund. So if you want to support our work, you can donate at our website, www.healthcare-now.org.